So we are ready to start. Okay, so hello everyone once again. Today we are moving a little bit to Germany. So as you say in German, willkommen. And today we have the opportunity to receive at our midi conference a talk from Professor Miriam Kunz from University of Augsburg. Professor Kunz studied psychology at the Free University of Berlin and received a doctoral degree in 2006. And in 2007, she came to Montreal at the Université de Montréal for the postdoctoral studies here at CRUGM actually with Professor Pierre Anville at CRUGM. In 2012, Dr. Kunz received the habilitation degree in psychology at the Otto Friedrich University of Bamberg, Germany. And further, Dr. Kunz moved to Munich, also Germany, at the Ludwig Maximilian University for the position of Deputy Professorship for Biological Psychology. In 2015, Dr. Kunz started her tenure-track professorship position at the University Hospital Groningen in Netherlands. And since 2019, Dr. Kunz is a university professor for medical psychology and sociology at the University of Augsburg. Her research priorities include experimental pain processing, pain recording in people with dementia, biopsychosocial basics of facial communication, and automatic recognition of pain and emotions. Dr. Kunz, thank you very much for accepting our invitation. Welcome once again to Montreal after something like 10 years, even if on Zoom. So the floor is yours.
Yeah, thank you very much also for the invitation. I'm very happy at least to be virtually back in Montreal, hopefully after the Corona crisis, also then in person soon. Yeah, I would like to talk today about pain written in the face, so about facial expression of pain, why they are of clinical usefulness, and what are the biopsychosocial mechanisms underlying these facial responses. Just as a very brief introduction into the topic. Let's see. Now I have, yeah, so now it works. We all know that we can communicate our inner affective states via our facial responses. This has been shown in lots of study for typical emotional states like anxiety, fear, happiness, anger, or disgust. But this is also true for facial responses to pain, that we show certain types of facial muscle movements when we are experiencing pain, and that by looking at those facial responses, other people can infer that we might be experiencing pain. And you might ask yourself, why is it so interesting or important to study facial responses of pain? There are for sure many reasons, but the reason why I got interested in studying facial responses to pain was because of my PhD thesis. So during my PhD time, we were studying pain processing in older individuals with cognitive impairment and without cognitive impairment, or in this case with dementia and without dementia. And we wanted to see how the new degeneration of the brain, how it might affect the way they are responding to pain or are processing pain. And we found, interestingly, as you can see in this example, the lady on the left side was an individual without dementia. On the right side, the gentleman was suffering from a moderate stage of dementia. And here you see facial responses to a pressure stimulus of 5 kilograms. And whereas this cognitively non-impaired lady could, of course, tell us how strong the pain was she felt, the gentleman on the right side, when I asked him how strong is the pain, and he was supposed to rate it on a very simple scale where he could choose between no pain, mild pain, moderate pain, strong pain, very strong pain, he just answered by saying good. So he was not able anymore to provide a self-report of pain, although you can see from his facial expression that he was clearly experiencing a painful experience caused by this noxious stimulus, this pressure pain. So this got me started to be interested. What is this facial expression of pain? Why do we show it? What can we learn from it? Can we use it maybe as a substitute for the self-report in individuals who are lacking the ability to provide a self-report of pain? So that was kind of like the starting point. So if this is the aim, to have the facial expression of pain as kind of a substitute for a self-report rating, the first question might be, how does this facial expression of pain look like? They are typical facial responses to pain that we can rely on as a prototypical facial expression of pain when we want to infer if somebody is in pain or not. And several studies have been conducted over the years that looked at facial responses to pain. Typically, they are analyzed by the use of this facial action coding system. It's an old system out from the 70s. It's anatomically based and tries to separate facial muscle movements into different so-called action units. And with the help of these action units, you can quite objectively and quite reliably code facial responses. And this facial action coding system has been used in several studies to study facial responses to pain. And across all these studies, what we published here in this review article, we could see that across studies, we find that individuals respond to pain by contracting, or when they are experiencing pain, they also show this contraction of the eyebrow, which is called this action unit 4. This is the action unit coding scheme of the facial action coding system. Or they respond by contracting the muscles surrounding the eyes, the action unit 6, 7, by lifting the upper lip till wrinkles occur on the top of the nose, the action unit 9 and 10, and then opening of the mouth. So these facial responses across studies were found. Mostly these studies have been conducted in Western cultures, but at least across Europe and North America, we find that individuals respond with these kind of facial responses. At least on a group level, across studies, we find these responses. And also what is quite important, most studies used experimental pain to induce pain because it's quite controllable, and thus it's easier to interpret what we can see on the face. But this facial action coding system has also been used to analyze facial responses occurring during clinical pain states. And importantly, we do find the same type of facial responses to clinical or during clinical pain states, the same types of facial responses, just with one add-on, namely this action unit 43, which is closing the eyes completely for longer than half a second. But you could see this facial response as kind of an exaggeration of this action unit 6, 7. So to an even higher degree, you squeeze up your eyes and you close your eyes in response or during a painful experience. So that's good news. If we want to use facial responses as a substitute for facial expression, at least there are certain types of movement that seem to reliably occur while individuals are experiencing pain. At least, as you will see later on a group level, we find this pattern of expression. The next thing, if we want to use facial response as a substitute, is the question, how do facial responses correlate with self-report ratings? Because if we want to use it as a substitute, we want to see kind of relation. If people are rating a situation or an experience as quite painful, do they also respond with an increased facial expression of pain? So that's when we correlate facial responses with self-report ratings, we see this pattern, what you can see here. So here are the ratings. So here we induced quite strong painful intensities between 70 and 90 for most individuals. And here you can see the facial responses coded with the facial action coding system. And here you see a pattern that we find over and over again. You can divide individuals into 3 groups. You have the non-expressors, which do not show any type of facial responses during these experimental pain testings, even for painful stimuli that they rate quite high, so around 90 or above 90, they do not show any type of facial response. And then you have the next third, namely those individuals which respond with some kind, slight facial responses that are pain indicative. And then you have the last group, 1/3, which is very facially expressive. And this is not, as I said, this is not only, we did not only find this in one study, but it's a pattern we find over and over again. Here, another study, the same pattern, 1/3 doesn't show any type of facial response, 1/3 slight facial expression of pain to experimental painful stimulation, and then 1/3 showing strong facial responses. So when you look at this data, this seems kind of discouraging, because if there is like zero correlation with self-report rating, how can we use then facial responses as a substitute if it doesn't really tell us in a group of individuals, at least, that we haven't seen before, who is in pain or not, if there are so many people who do not express anything via their face, even though they are reporting to be experiencing pain. What we thought about is maybe it's not a good idea to start looking at this relationship just on a between subjects approach, but maybe we should look within an individual. Maybe it's not possible in a group of individuals to know this person who is expressing the most pain would also report the most pain. But maybe it would be better to see on an individual basis. Maybe there it's possible to find a relationship. So for a person who is maybe more stoic, if this person shows at least a slight facial response, maybe that's already an indication that pain for this person is increasing. Whereas for highly expressive individuals who's always responding a lot with the painful expression, even in this individual, if the facial response increases, maybe that will tell us if the pain for that individual person might be increasing. So maybe we should look more on an individualized approach within subject instead of just the between subject correlation. That's what we actually did quite early on. That was in my early stages when I started to be interested in facial responses. Because what we observed here, these are the 5 kilogram, and before you saw the video of these older individuals to this 5 kilogram response, you see that the subjective ratings, pain intensity and pain unpleasantness, increase across intensities. But here, when you look at the facial response, you can see something which is quite typical for facial expression of pain, namely that the threshold for facial responses to start is first of all higher than the self-report of pain. So we only start expressing or communicating pain via our face when it has reached a certain intensity. So most people don't start when it's only a slightly painful experience, but the pain has to reach a more moderate stage before people start to also express it via the face. So here it seems to start only at the intensity of 4 kilogram, but then you can also see this increase from 4 to 5. And what we did is we calculated now the slope in self-report ratings and the slope for facial responses, and we correlated the slope of increases of these two facial pain responses between facial and subjective responses. And here we did find a significant correlation. Again, you have here the non-responders. That's always something we have to take into consideration. Even showing no facial expression of pain does not mean that the person is not experiencing pain, but there are some stoic individuals. That's always something we have to keep in mind. But for the rest, for those who are expressing pain, we find this significant association, even significant when in this correlation, we also included the stoic individuals. So the more for an individual, the facial response increase, this also goes along with an increase for that individual in self-report ratings. Meaning on an individualized base or individualized approach, you can, based on the facial response, if you observe an individual over time, you can know whether the pain for that person increases or decreases. It's just not possible on a between subject approach that just simply based on the facial response, you know how much pain the person is experiencing. So that's for the clinical usefulness. We need to have an approach to look at the facial expression of one person over time and look at increases and decreases, and that will give us some information whether the pain the person is reporting might also be increasing or decreasing. So, but now starting with these individual differences. that we do find that it's not really possible on a between subject approach to know how much pain somebody is experiencing just by looking at the facial expression. Where are these variations coming from? Why do people differ so much in the degree to which they express their inner state pain via their facial response? When looking at inter-individual differences, as a psychologist, you always think about learning. Maybe learning plays a role. Maybe people learn differently to express pain via their facial response. So in the first study, we wanted to look at a very basic form of learning, namely visual learning, to see whether looking at other people's facial responses to pain might be important for the way that we are expressing pain. And in order to investigate this, we used two groups, namely a group of healthy controls and a group of congenitally blind, so born blind individuals who have never in their whole life seen a facial expression of pain. And because if visual learning does play an important role in facial responses to pain, then we should see big differences in the way these two groups are responding to pain facially. So we induced pain 3 intensities, very mild, mild, and moderate pain, and we assessed self-report ratings in facial responses and analyzed the facial responses with the facial action coding system. And here are the results, just as images for clarification. So we did find that congenitally blind individuals, they are wearing this neck holder thing. It might look a bit weird, just because usually we tell the sighted individuals, please look at this picture or at the wall in front of you. But because we couldn't give this instruction to the congenitally blind, we just had them wear this neck holder thing, so to make sure that they're not moving the face out of the camera view. And what we found is that if you think about the facial movements that occur during the experience of pain, we found that they show the same type of facial responses. You see here the corrugator contraction, the contraction of the eyebrows. You see the contraction of the muscles surrounding the eyes. And for these individuals, you don't see this levator contraction, but this also occurred. So the type of facial response was the same, showing that the type of muscle movements elicited during the experience of pain learning doesn't seem to be important. It seems to be more inborn what type of facial muscles we are contracting when we are experiencing pain. But when we looked at the increase across intensities, we found significant group differences. In the sighted individuals, the facial response increased from very slight pain to mild to moderate pain intensities. We saw an increase across intensities, but for the blind individuals, we did not see that. Just when pain occurred, we saw an increase, but it didn't really increase across intensities. So based on this, visual learning seems to play a slight role when encoding different pain intensities via our facial expressions. And you have to keep in mind, this is not really a big intensity. We are not really comparing very mild pain to very strong pain, but these are all very close to each other. So you need visual learning, it seems, to be able to differentiate slight differences in pain intensities with your facial response. Another type of learning is, of course, operant learning. So the question we asked ourselves, maybe operant learning plays a role if a child is reinforced all the time when they are expressing pain, with the parents reacting to like, oh no, you're in pain, I'm so sorry. Do you want to watch your favorite show and want to eat some ice cream? Maybe that leads to an increase in facial responses because of operant learning mechanisms, whereas, for example, punishment, you're in pain, then you have to stay in bed, you're not allowed to play with your friends. Maybe that would lead to a decrease in facial responses. And we wanted to test it experimentally. We induced pain and had kind of like a hidden story. And we told the people that we are looking at their heart rate variability and attached all the electrodes and told them that heart rate variability plays an important role in pain perception. And we wanted to see whether just based on on reinforcement or on feedback, they are able to modulate their heart rate variability responses in response to the noxious stimulus. And we told them, if your heart rate variability changes in the intended direction, you will get a positive feedback. Each time it changes in the positive direction. And the faster you learn, the shorter, the less amount of painful stimuli you will receive. That was the cover story. But of course, we didn't look at the heart rate variability, but we looked at the facial expression. And we had an up-conditioning trials or procedures where we always gave positive feedback or reinforcement when they showed facial responses to pain. And then we had a down conditioning block where they received positive feedback when they showed a stoic facial response in response to pain. And the outcome you can see here, we had an experimental group and a control group, and in the experimental group, we were quite successful. So reinforcing facial responses led to an increase in facial response, whereas reinforcing the stoic expression led to a decrease in facial responses to pain. We also checked how stable these changes were. They were not super stable. So you can see it declined again, but was still a little bit higher than the baseline. And here also the decline in facial responses, we saw an increase again, but this it was still much decreased compared to the baseline compared to this up conditioning. So even a short manipulation check, you could say, for half an hour led to a change in facial responses that even lasted longer than even after we didn't give any reinforcement anymore. We could still see this slight change in the degree to which an individual is willing to show facial responses in response to the noxious stimulus. So based on this, we could say, yeah, operant learning seems to play a role because we were able to replicate it, or we're able to show it in a short experimental paradigm. But if we look at operant learning, we know that it's very specific, that we do not learn to always decrease or increase our behavior, but in operant learning mechanism that we do it quite differentially depending on the social situation, that we can learn in which social situation is it appropriate to show this or that kind of behavior. And this is seems also to be true for facial responses to pain, based on these social display rules. In which situation should I express emotions or pain, to which degree? And we studied individuals in 3 situations. First, they were alone in the room. Then in another block, they were together with their loved one, with their partner. And then in a third block, they were together with the experimenter. And we looked how they facially responded to these painful stimuli in these 3 social situations. And we found that while they were together with the experimenter, they showed a decrease in facial responses. And while they were together with the partner, their facial responses were increased. So again, showing that social learning, social situations might be important or seem to be important to regulate the degree to which we communicate pain via our facial response. So taking it together, these studies so far show that learning does play some kind of role, with visual learning being important to be able to encode slight differences in intensity, and operant learning and social situations or social display rules also seem to modulate to which degree we express pain via our facial response. But if these learning mechanisms are so important, then it is quite surprising when you look at these 2 videos that these 2 ladies, who are of the same age, both are psychology students, both have been growing up in Bavaria, so both have visual learning, probably learned similar social display rules, maybe also had similar family backgrounds, with reinforcing or punishment, both being girls, so maybe it was more appropriate also for them to show facial response. You now see their facial response to a painful stimuli. They both received a painful stimuli that they both rated as moderately painful. But as you can see, the lady on the left side, or the woman on the left side, is expressing much more pain via their facial response compared to the woman on the right side. So how can that be? I mean, here, visual learning, social learning should be very comparable, but still we find these great variations in the degree to which they express pain. So we are looking what, besides learning, what else, what other mechanisms might play a role that help us to understand these variations. And we were thinking about personality traits. We checked for personality traits. Maybe the questionnaires are not good enough, but so far, no correlation. Personality traits do not really correlate that well with facial responses. So we thought about other mechanisms that might play a role. And then we came up with, if social display rules for negative affective states, pain would belong to the negative affective states, we know that during childhood, we learn to inhibit these negative affective states. So our idea was maybe both of them learned the same display rules, but are less able to act on these learned display rules. So maybe the ability to inhibit, the ability to act on maybe the same type of learned display rules might play a role. And that was the next endeavor or the next road we wanted to investigate, whether variations in facial expression of pain might be related to the ability to inhibit. With this idea, social display rules, we learn to inhibit negative affective states, including pain. So maybe the more facially responsive individuals are less likely to really do this, because they are less likely to inhibit facial responses. So in order to investigate this, we looked at inhibitory tasks, and especially at this anti-saccade task. So I don't know whether you are familiar with this. I will quickly explain how it works. It's an eye tracking task. So you look at this fixation cross, and then a circle appears, and there are two conditions. In the pro-saccade trials, you are instructed to look at as fast as possible to the circle that appears on the screen. And in the anti-saccade trials, you are instructed to look as fast as possible away from the circle occurring on the screen. And then you can calculate how long does it take the individual to look away from the circle in the anti-saccade task, and compare it to the time during the pro-saccade trials, where they should focus on this novel stimulus appearing. And because it's a novel stimulus appearing, you have an automatic pro-saccade towards the salient new stimulus. And you have to inhibit what is naturally occurring as an automatic response. You focus on the novel stimulus appearing. You have to inhibit this automatic motor response and move your eyes away from the target. And in another block of the experiment, we induced pain and just looked at the facial responses. So for the participants, these were two separate blocks. In one block, looked at inhibitory functioning, and the other block, we looked at pain responses. And then we correlated the two. Here we assessed facial responses with the facial action coding system, but also with EMG. And for both, we found significant correlations with the anti-saccade task. Those individuals who had more problems inhibiting the automatic pro-saccade response and looking to the other side, those individuals with longer latencies were also the ones who showed more facial responses to the painful stimuli. So that was our interpretation. If you are less able to inhibit an automatic motor response, you show more facial responses, maybe because you're not able to inhibit these automatic motor responses, your facial expression, as well as those individuals who show better ability to inhibit automatic motor responses. So maybe this ability could explain or could at least contribute to explaining the variability in the degree to which we express pain. And then following up on this line of thinking on this inhibition, we also thought maybe the neural mechanisms will also help us to understand the variance in facial responses to pain. And that's the study I did together here with Pierre Renville in Montreal during my postdoctoral stay. We studied students, we induced pain in the scanner and assessed self-report and also the facial response and brain activation. And the individuals, they didn't know it was about their facial response. It was only the slide camera that we put on the head coil of the, put it in the head coil, and the individual, it was quite small. Most individuals were not even aware of it. So they didn't know it was about their facial response. But we made sure that we included individuals with different degrees of facial responses. It was not just, we didn't select very expressive or non-expressive ones, but as you know, we always have these 1/3 non-expressive, 1/3 mildly expressive, and 1/3 highly expressive. And then we just wanted to see what happens in the brain for when these individuals are experiencing pain and expressing pain. We find some explanation why some people are more stoic than others. In order to do this, we correlated their facial response with the brain activation. And we found here the negative correlation that the less expressive or more stoic an individual was, the higher was the activation in medial prefrontal areas as well as in striatal areas. So adding on to this impression that the ability to inhibit may here as or shown as or indicated as a higher activation in medial prefrontal areas seem to be important in order to inhibit our facial response, or here in other words, the more expressive the individuals were, the more did they deactivate the activation in the medial prefrontal area. So we need to decrease this inhibition in order to let something through to show what we are feeling via our facial response. And because this is just a correlation, and this is difficult then to say, is really the medial prefrontal cortex, is it a causal relationship? Is really the medial prefrontal cortex the reason why they are showing less or more facial response? And in order to investigate more the causal aspects of it, we did a follow-up study where we tried to modulate the activation in the medial prefrontal cortex using repetitive transcranial magnetic stimulation. And what we did is we tried to decrease the activity in the medial prefrontal cortex, because if it's true that we need the medial prefrontal cortex in order to inhibit our facial expression of pain, if we disrupt this activity, this inhibition should not work anymore, and thus people should become more facially expressive. So after we did the RTMS stimulation, we also had a sham stimulation over the same area. We also induced pain, heat pain and pressure pain, and then assessed self-report and facial expression. And what we found is, as we were hoping for, or what our hypothesis was, that after we disrupted the activation of the medial prefrontal cortex by using RTMS, we found an increase in facial responses to pain. That was true for pressure pain as well as for heat pain. So again, adding on to this idea that we need the medial prefrontal cortex to inhibit our facial response. Or if we want to put it here in pictures, I tried to make a graph out of it. When we look at facial responses, we cannot perceive facial responses as a perfect mirror of our inner affective state, but people vary in how they encode pain. Some are more expressive, some are less expressive. Learning seems to play a small role, but maybe the most important thing is this learning of inhibition, and that depends on maybe your ability, on your culture, but also on your ability to inhibit that automatic response. And this ability to inhibit the automatic motor responses seem to be governed by the medial prefrontal cortex, or at least the medial prefrontal cortex seem to play a big role. And the way we think you could imagine it is as if there might be an inhibitory gate that you control to open, and in order to let something through. So you learn to build up this inhibitory gate throughout your childhood based on social display rules. And then you can regulate it in which situations you open it up, so more comes out, or you close it down, so less comes out. And this ability to open it up and close it down might be related to your overall ability to regulate automatic motor responses. And the neural correlate for this might be the medial prefrontal cortex. This is kind of explaining the variability in the intensity of the facial response. But in the next 5 minutes, just more shortly, I also want to show you that it's even more complex. So people do not only vary in the degree to which they express pain, but they also vary with which type of facial muscle movements they are using to encode the state of pain. Even though I told you across studies, we find this pattern: contraction of the eyebrows, contraction of the muscles surrounding the eye, upper lip raise and closing, and opening the mouth, or closing the eyes for longer than 5 seconds in clinical pain. We do find on an individual base lots of variations. Just as an example here, this was experimental pain, but you can see people vary a lot. And so we thought, if we want to use the facial response for clinical pain assessment, we need to understand better what these variations mean. Is it just all over the place, or do we find at least clusters or pattern of expression that help us to kind of categorize facial expressions of pain? So what we did is we used, in a sample for experimental pain, we used cluster analysis, and we did find clusters that occurred across trials. Again, we have these stoic individuals. We always have these stoic individuals. Even in clinical pain, we have these stoic individuals. But for the rest, we found 4 patterns. And one was contraction of the muscles surrounding the eyes. I also tried to put it here in avatar facial movement, so it's maybe a little bit easier to see. What we found is one pattern was contracting the muscles surrounding the eyes with a little bit of frowning and a little bit of upper lip raise. One contraction of the eyes paired with opening of the mouth. And this was something weird, that people looked more surprised, lifting the eyebrows. And then we found a pattern with contraction of the eyebrows being the most dominant one, combined with closing of the eyes. This was for experimental pain, and we just recently did the same thing for clinical pain states. And here we found very similar patterns, except this lifting of the eyebrows we didn't find. Maybe that was just a surprise response to the experimental pain. But here again, we found contraction of the eyes being the most dominant one for this pattern, combined with a little bit of frowning. Here, opening of the mouth combined with closing of the eyes. And here, frowning being the most prominent one, combined with closing, contraction of the muscles surrounding the eyes. So we find there seems to be some pattern. And if we want to really simplify it, I think that's mostly the truth, that people, what all of these facial expressions have in common is the contraction of the muscles surrounding the eyes. And this is paired individually differently, either with lifting the upper lip, or with contracting the eyebrows, or with opening of the mouth. So this is what they all have in common, but depending on the person, the combination with which this action unit is shown can differ. But that's kind of like the systematic in this variations of what people are expressing when they're experiencing pain. This is the common ground, the action unit 6-7. And when we look at these different combinations, our question was, are these movements expressing different aspects of pain? Because pain is complex and multidimensional. And if we want to easily differentiate it, we at least have the sensory aspect and the unpleasantness aspect. So we wanted to see, are these facial responses maybe differently related to the sensation, pain sensation or pain intensity, or the unpleasantness aspect of pain? And this is also something I did while I was in Montreal, this study. And we tried to use suggestions to increase pain sensation in one block, and in another block to increase pain unpleasantness or the pain affect, and wanted to see what happens if the subjective experience of pain sensation, how intense is the pain, the throbbing of the pain on the leg, when we increase this sensation compared to increasing pain affect, the unpleasantness of it that is running through the whole body, and more the emotional aspect of it. And here we could see that the face changed depending on what we increased. When we increased pain sensation, we found increase in the eye movement, the contraction of the muscles surrounding eyes. And when we changed pain affect, we found a significant change in the lifting of the upper lip and the eyebrow contraction. So going back to this presentation here, like this seems to be more the pain intensity that is encoded, and all people, because it's part of all clusters, seem to encode the intensity of pain. They just differentially pair it with more action units or facial muscle movements related maybe to the unpleasantness of the experience. That was what we took away from it. And we also did put these individuals also in the scanner to see what happens in the brain when during the increased pain sensation, when they show increased contraction of the muscles surrounding the eyes. And we also found that this increase correlated with an increase in S1. Again, suggesting that it's more the intensity dimension that seems to be encoded in this eye movement, in this contraction of the eyes. Okay, so summarizing this aspect, this is still German, sorry, this should be pain. We see that both aspects of pain, the sensory as well as the affective dimension of pain, seem to be encoded in the face, the sensory dimension more in the eyes, and the affective dimension more in other movements like the frowning or the lifting of the upper lip or opening of the mouth. Now coming to our last part, or back to the beginning, how I got interested in facial responses of pain, namely in those non-verbal individuals with dementia who are not longer able to use facial responses. What I found in this study, in my PhD study, was, and I could replicate it again in other studies, is that the individuals with dementia show stronger facial responses to pain. Based on the other findings I showed you, that's quite comprehensible, because maybe they lose the ability to downregulate their facial response. Maybe they lose the ability to inhibit their facial expression of pain. And that's why they show it more strongly. If this also goes along with an increased pain experience, it's hard to tell because we cannot ask them, because they wouldn't tell us anymore. That's difficult, but at least they clearly show it on the face, which might be a pro or an advantage, because for those who lose the ability to report about pain, at least they also lose the ability to inhibit the facial response. And then the facial response might be a more valid way to know whether they're feeling, because maybe we have less stoic individuals and individuals with dementia. So that might be an advantage for the clinical practice when assessing pain. So the face could be used as a way to assess pain in individuals with dementia, because they're expressing it higher. The problem is how we do this now in clinical practice. We could, of course, look at the person during clinical care using observational scales. That's one way to do it. But this only covers like 5 minutes maybe in the morning. So what about the rest of the day? And here, kind of like a novel ideas are starting to use automatic analysis of facial expression of pain in individuals with dementia. Just look at the face video recorded while in the nursing home, while in the hospital, and maybe use this information to know whether they are in pain or not, if they cannot report about it verbally anymore. And that's what will be the last few slides of my talk, just to tell you it's a great idea, but we are not there yet, unfortunately. The way how these automatic systems work, they all work similarly in the way that, first of all, they locate the face and they locate facial landmarks in the face, like the eyebrows or the eyes. Because of color edges, they can detect the face and the facial landmarks. This next step is in the moving face, they look at displacements of facial landmark points to see whether a movement occurred. And then some of them also use texture information. Some of them then, based on the displacement of landmarks, they come up with the action units from the facial action coding system, or they directly infer whether the person is in pain or not. Okay, that's the way they are working. Where are the problems? The problem is the older faces, because these images or these systems have been mostly trained with young faces, and in young faces you can see it's quite easy to look at the color edges to to differentiate the skin color from the eyebrow color or the lip color from the skin color. But if you look at this older lady, you can see that it already starts here to become difficult, because here the edges, the color edges, are not that clear. If you look at the eyebrows, like this could also be a color edge, the wrinkle, or here the mouth, the lip color is not so different anymore from the skin color. So the systems often have problems setting the facial landmarks on these very old wrinkled faces. And here's one study which looked at the facial landmark, which is the first step of the process. So if the first step is already flawed, you know, even more errors will occur later on in the process. And as you can see here, for example, at the jaw, it's only, H means healthy older individuals and D means dementia. So here from the jawline, the facial landmark detection only, these are percentages. Sorry, I should have said that before. 100 would be perfect landmark placement. And here you can see only in 25% was the landmark placing correct. And for the brows, which should be quite easy, at least in young faces, you see in older faces with and without dementia, it doesn't work that well, that it's only in half or less than half of the cases that the landmarks were set correctly. And that's the problem, that already at the first point we have problems. And then if you look at the second step, displacement of landmark points, how do these work? For example, open eyes, and here you see typical pain response with the contraction of the muscles surrounding the eyes. So the eye aperture becomes more narrow, and then you can see the difference in the eye aperture, and this gives you an indication that that a movement occurred. But if other things occur, for example, that the person just looks down, you have the same difference in eye aperture differences. So here the system could make an error and interpret this one as the same movement as the one above, although this has nothing to do with a contraction of the muscles surrounding the eyes or with a pain expression, but this is just caused by looking somewhere else. And then the texture information, which works quite well for younger people, because as you can see here are no real wrinkles, and here more wrinkles occur. So texture information, wrinkles occurring on the skin, which is quite good in young individuals, is a disaster in older individuals because they already have wrinkles. And if the texture information is then used, you see them making facial responses all the time, although they're not really moving their face. And then if you also look at data for the third step, namely saying whether facial action units occurred, there have been some studies now doing this, comparing facial action coding system coding by human observer with the automatic one. So the true one is the human observer, who saw in more than 150 cases saw action unit 4. This is the contraction of the eyebrow. And in more than 600 cases, didn't see this action unit occurring. And then you can see the prediction is quite bad insofar that, it detected most of the movements, but quite often it also detected a movement, although no movement occurred. And there are different systems on the market, and most of them have similar problems. That's the face reader that we used, and here we find very similar patterns. So to sum it up, the idea to use automatic coding systems for decoding facial responses is quite promising, and probably in a few years we will get there, but so far we are not there yet. And the most important thing is, I think, that these systems need to be trained with older faces and not with young faces, because that's, I think, where most of the error is coming from. And I'm done with my presentation. I thank all my collaborators, and I thank you for your attention.
Thank you very much, Dr. Kunz, for this wonderful presentation. So now we will take the questions. So please raise your hand, activate your microphone, and feel free to ask the questions. Or you can also write the questions in the chat, and I will read them. Okay. So I will start. Okay. I will start with the first question. That is a quite interesting, thought-engaging presentation, especially for the link between facial expression and potential emotions, because this is my direction. I was wondering if there are, from your perspective, your experience, if there are any potential relationships associated with emotions and facial expressions just by looking at images of the muscles that were contracted. It seems that there is a probably biased impression that some individuals would trigger the fight response, or would aim to trigger the fight response, while others would trigger the run response. Is there any link with this type of emotions, or you didn't?
I haven't really looked at this, you're right. And we were also thinking about this aspect, whether this could play a role that for some, like, but now you mean more on the decoding part, don't you? That if you look at those facial responses, or not at the encoding part, that people are showing this type of response, but how are people responding to these different facial expressions? Is that your question?
Yes, well, like contracting the eyebrows due to pain probably might, an automatic behavior would be something like a fight response, I presume. I'm not sure about that.
Yeah, because you think it's more like related to angry expression. And then the flight, you would think, is more the surprise, or?
Probably. So if the fight response is present, probably there is also a run response, but I don't know.
Yeah, no, that's an interesting idea, but we haven't really looked. But this could be another way, because we still have so much variance between individuals, and we always only explain like a very tiny portion of it, like 5% here, 3% here. But this could also be a difference why people express it differently.
Thank you. So we have a question from Tore Nielsen. Thank you for the interesting talk. Have you examined facial EMG differences? I wonder if stoic individuals may have more covered EMG pain expression.
Yeah, the problem is sometimes that we think we can either use EMG or facial response, because something like in this one study we did, but then you cannot cover the whole face. You can cover the corrugator quite nicely. The orbicularis oculi is also sometimes problematic if people with the blinking response sometimes. So we have looked at it, and it's true that for the correlation, this one study with the anti-saccade task, we saw that the stoic individuals, of course, are not stoic anymore if you look at EMG, because then you never gain a zero. So we found like a little bit of a smoother correlation between it, and it's like that's also what I would think that with the, but we haven't systematically investigated it. But you're right, I'm sure stoic individuals are not completely stoic, because that's also something interesting. When we ask people, how stoic are you, or how facial responsive are you? People have zero idea how facial responsive they are. There's no correlation with their real facial response, because people always judge themselves to be more facially responsive than they are. And I think because maybe they do show slight movements that are captured in EMG, but which get lost then in the FACS coding, because here you have to see visual movements of the skin, and for the skin to move, the contraction needs to reach a certain amount. So I agree with you, EMG would in this case is better, would be a bit better. It's not as good, of course, to differentiate which type of movement was it, at least for the lower face. If you're smiling or doing this just with the big EMG electrodes, it's more difficult to differentiate. But we are now collaborating with an Israeli lady, and they developed a foil that you can put on the face, which doesn't weigh anything, and which makes you move your face quite normally. So you're just testing this now to use this more in our experiment.
Oh, this is interesting. Thank you very much. So we another question, since the prefrontal cortex is potentially a brain region that would inhibit the facial expression, when considering the potential increased facial expressions in patients with dementia. So the question would be, well, the prefrontal cortex is the last one that is being developed in the human brain. So the question would be, are there any differences relating to pain expression in adults and children?
And they go, yeah, they are, and they go in this direction, that children are more facially responsive, and starting from school age, they kind of learn to inhibit it, and it's also the inhibition they report about, and you can also see that they become less facially expressive to pain and also to other negative affective states, which is then in line with these social display rules, which are coming from the negative affective states and also development in children. The children, when they get older, they are better able to regulate it, and they show less facial responsive during negative affective states.
Okay. Interesting approach. Okay, thank you very much. So do we have any other questions? Okay, so okay, Dr. Kunz.
I have a question.
Yep, Benjamin.
Hello, thank you very much.
We cannot hear you, sorry. Can you
hear me?
I can hear you. You have to just move a little bit closer to the microphone.
Okay, sorry. Just a quick question. I'm interested in effort, exertion of cognitive and physical and cognitive tasks. And in your experiments, your pain is induced in a passive condition most of the time. And when you are active, you exert effort, and you also frown the muscle, and you have like facial expression of effort. Do you know if it's possible to dissociate the facial expression of effort and the facial expression of pain during active condition?
Yeah, it's the differentiation aspect is pretty bad. We are not there yet, because the problem is, I think, this facial action coding system is quite good to differentiate which muscle movements occur, or which visible facial muscle movements occur. And you also code the onset and offset. But I think machine learning will help us, because I think it will be possible to differentiate them if you look at the timeline of facial movements. And I think there the timelines will be different for pain, anger, effort, even sexual arousal looks super similar. There's a study which compared facial expression recorded during orgasm and during pain, and people were not really able to differentiate them, at least from photos. That's what I mean. I think the timeline of the expression, there is information encoded in the timeline of it that we don't really analyze, because by hand in SPSS it's not really possible. But I think if we put this in machine learning and look for clusters or pattern, I think we will find something.
Okay, thank you. Super interesting. Thank you very much.
Okay, I'm sorry, Benjamin. I still didn't hear you, but it's good Miriam heard you.
I just said thank you very much. It's very interesting. Sorry.
So thank you very much. Are there any other questions? Okay, so okay, such an engaging talk. That was such an engaging talk. Here is a comment. So thank you very much, Dr. Kunz, once again for this very excellent, thought-engaging presentation, and very interesting that your results were so well developed, especially with confirmation from the TMS studies. That is interesting. Also vielen Dank für Ihre hervorragende Präsentation.
Merci beaucoup.
Okay, so that would conclude the CRUGM conference for today. Thank you once again, Dr. Kunz. Thank you very much, everyone, for attending our conference.
Bye.
Bye.